Well, hello there, everyone, and welcome. On behalf of Abbott, we want to thank you for taking time to attend today's program, Non-Transplant Programs and the HeartMate 3 LVAD. This is presented by Dr. Asim Afzal and Dr. Brian Howard. We're happy to have them on board. The content in this presentation does represent the beliefs of our speakers and does not necessarily reflect the views of Abbott. Information being presented today is consistent with applicable FDA guidelines. This content does reflect the speaker's experiences, so the applicability of this experience should be considered in the context of your individual centers and your patients' needs. The speakers are presenting at the request and on behalf of Abbott, and an honorarium is being provided. This meeting today not intended for CEU credits, and again, support for the program is provided by Abbott. With that, I would like to introduce our two speakers here today. First off, Dr. Afzal is with us. He is the Medical Director of Mechanical Circulatory Support and the Program Director for Advanced Heart Failure, Transplant, and Circulatory Support at the Heart Hospital Baylor Plano. He specializes in treating patients with advanced heart failure. Also, he holds a Master of Business Administration with a focus in healthcare management from the University of Texas at Dallas. And he's joined today by Brian Howard. Glad to have Dr. Howard on board. Dr. Howard developed the Advanced Heart Failure and Left Ventricular Assist Device Program at Wellstar Kennestone Hospital in Marietta, Georgia. He now serves as the Medical Director of the Wellstar Health System Heart Failure Program. His primary interest is in promoting quality improvement and expanding access to advanced therapies for heart failure patients across the state of Georgia. And we appreciate both these gentlemen taking time to join us here today. And with that, my pleasure to turn things over to Dr. Afzal so we can get into the conversation.
Thanks, James, for the kind intro, and thanks everybody for joining us today and giving me the opportunity to talk. So just quickly going over the agenda for today, we're going to go over heart failure briefly and epidemiology, as well as kind of how non-transplant programs function. And then we're going to change some gear and go into heart failure clinical outcomes and talk more about patient evaluation, selection, collaboration with transplant programs, case studies, and then we'll take it from there to questions and conversations. So with that, I will go ahead and kind of start talking about heart failure. So we already most of us are practicing in the field of cardiology and know the implications of managing heart failure. There's 6.7 million adults in the U.S. with heart failure. There's a 50% mortality rate within 5 years of diagnosis. And sadly, we haven't been able to move that needle on in terms of mortality rate, despite all the advances that we have had, partly because that we have issues with access. There's about 600,000 patients that have advanced heart failure. That's about 10% of the population with heart failure. And over 377,000 deaths are attributed to heart failure in the United States alone. That's a huge number if you think about it in terms of the disease burden of heart failure that we're taking care of in just the States. And why is that all important? That if you look at it from a global perspective, we have about 26,000 patients that have advanced heart failure for which LVAD would be indicated. And out of those 26,000 patients, about 1,000 patients are transplant eligible. There's about 3,500 LVADs that are implanted. But if you look at the number of patients that have an unmet need, that is a staggering 83%. So we still have a lot of patients that we can help. And that we need to figure out how to manage that and how we can get patients as well as our partners in the healthcare space to get the patients to the right facility so that we can get them the help that they need. What we also see from a disease burden standpoint is that with heart failure, with repeat hospitalizations, you see a progressive increase in mortality rates and a decrease in survival. So after the first hospitalization, an average survival, a median survival is about 2.5 years. And that decreases with the second hospitalization within the year. And if you look at it from the 4 hospitalizations over a short period of time, you're talking about only a half a year of survival on a median basis. And so readmissions is a very big telling sign that we need to do something different. We need to start thinking outside the box of what we have done in terms of medications and see what we can do to help the patient and change that survival outcome for this patient. So let's talk about heart failure centers across the country. So we have about 140 active heart transplant programs that are UNO certified in the United States, and they're kind of staggered throughout the U.S., but more more closely in high population density areas such as the Northeast and the West Coast and in South in Texas. There's about 120 hospitals that are designated as durable mechanical support centers. So these are the DT LVAD programs, and I practice at one of those programs. There are about 70 heart failure accredited, AHA accredited centers in the country. But the reality is that vast majority of the hospitals, if not every hospital in the country, is taking care of a heart failure patient. And most of the care for the heart failure patients are not being done at these DT centers or at transplant centers or at these AHA accredited heart failure centers. They're being done at centers that are just basically in the rural community, in the community setting. And a lot of times those patients do not get to see a heart failure transplant cardiologist. And that's why the focus should be on collaboration between heart failure centers and these community hospitals so that we can provide the care that we provide, the same level of care at a heart failure or a DT LVAD center or a transplant center at these locations as well. And that's kind of, in terms of a population management standpoint, that's kind of how we as a team need to think about this. And that's kind of how our landscape is right now from a heart failure standpoint. And if you look at the implications of this, you will see that rural patients have higher rates of mortality because of this lack of access of care. And we see this despite going through the last 2.5 decades of improving our healthcare and our access in the United States. And that gap continues to remain and persist. So let's talk about a non-transplant heart failure program. So typically a non-transplant heart failure program has a smaller footprint. Care is more focused on a heart failure management than advanced therapy evaluation. A lot of the non-transplant heart failure programs are going to be taking care of a lot of the systolic and the diastolic heart failure patients. They're going to be managing HFpEF. They're going to have a dyspnea clinic. A lot of it is done by a heart failure champion, a cardiologist who has a passion for heart failure, not necessarily somebody who has gone through a whole year of additional board certification or heart failure transplant training. And they tend to collaborate very closely with a center that has advanced therapies available. So this would be a center that does cardiogenic shock management with ECMO and Impella and such, or they have a DT or a durable mechanical circulatory support center there, or they will have a transplant program. Some of the limitation a non-transplant heart failure program has is that there will be limitations in terms of infrastructure, in terms of the subspecialists that are available on site, and in terms of bed control, and in terms of having other services such as multiple CT surgeons on site, or having subspecialists like rheumatology, endocrinology, dermatology that you typically take it for granted in a big academic program. So how do you function in this setting? A successful heart failure program, again, in these settings, need to focus on population management. And what that means is that you want to take care of the heart failure patients. You focus on readmissions. You start looking at patients that are at risk of needing or are identified as possible candidates for advanced therapies and get them to a point where they're not getting readmitted again. And we come up with a plan to get them to a facility where they can get that advanced therapy that they need, whether that's an LVAD or a transplant. And that's kind of how these programs evolve. You start off as a heart failure program, you get enough of a threshold of a volume of heart failure patients that you're taking care of, you get really good at it, you get accreditation for it, and then you naturally evolve into becoming a durable support center. And that's honestly the evolution that you will see at most of the DT-VAD centers, including our center itself as well. So with that, I will transition to Dr. Howard so he can kind of talk more about LVAD outcomes as well as survival data. Dr. Howard?
Thank you, Dr. Afzal. So over the next few minutes, we'll review a comparative analysis of outcomes associated with the HeartMate 3 LVAD device versus heart transplant, utilizing data from the Momentum 3 clinical trial and UNOS registry data. This work was first presented by Dr. Nir Uriel at the European Society of Cardiology Heart Failure Association conference earlier this year in Belgrade, Serbia. So as we know, younger patients have improved survival after heart transplant when compared to older patients. But median survival remains less than 14 years, even in patients ages 18 to 39 years, as shown in the graph on the right. And we also know that younger patients are at lower risk of mortality with LVAD therapy, with lower rates of bleeding and neurologic dysfunction. In this context, the strategy of electively bridging younger patients with an LVAD first, prior to heart transplant, has risen to the forefront in order to facilitate this phenomenon that we're describing as net prolongation of life. And I'll elucidate that concept a bit more in future slides. To provide evidence for this strategy of prolonging life, Dr. Uriel compared 2-year survival in the HeartMate 3 patients versus transplant patients before and after propensity score matching. Prior to propensity score matching, shown on the left, the 2-year survival in patients less than 50 years old was 92.2% with transplant in the dark blue line and 88.8% with HeartMate 3 LVAD in that lighter blue line. This difference was not statistically significant. And then after propensity score matching on the right, the 2-year survival was nearly identical in each group at approximately 91%. And the survival curves were essentially superimposable. Now, for those unfamiliar with propensity score matching, this statistical method allows us to compare like patients in one group to like patients in a second, so that we're essentially comparing apples to apples and minimizing confounding bias. This slide compares outcomes for HeartMate 3 LVAD patients less than 50 years old versus those patients listed for transplant. So not necessarily transplanted, but listed. Prior to propensity score matching, again shown on the left, the freedom from death or delisting due to clinical deterioration was 88.8% in the HeartMate 3 group and 84.5% in the transplant group. And then after propensity score matching, the magnitude of this difference increased, with a 90% freedom from death or delisting in the HeartMate 3 patients versus 78% in transplant patients. Notably, this difference was strongly statistically significant with a p-value of less than 0.0001. It's important to again note that this portion of the survival analysis incorporates patients that died or were delisted prior to transplant, unlike the prior slide. And in doing this, we see a truly remarkable survival benefit in the HeartMate 3 group in patients that are less than 50 years old. Again, 90% 2-year survival in the HeartMate 3 group versus 78% in the transplant group after propensity score matching. The comparative analysis also examined adverse events in the LVAD and transplant populations, again, before and after propensity score matching. We'll start with the stroke rate, as stroke is one of the most feared complications of LVAD. Stroke is displayed in the middle 2 bars on each graph, and while the debilitating stroke rate in the LVAD population was quite low at 2 to 3% of patients, there were more debilitating strokes in the HeartMate 3 group, both before and after propensity score matching. However, this risk was balanced by the increase in risk of both renal failure requiring dialysis and major infections requiring hospitalization seen in the transplant group. In summary, Dr. Uriel concluded the following. In a propensity-matched analysis of young heart failure patients ages less than 50 years old, number one, survival outcomes were similar between HeartMate 3 LVAD patients and transplant patients. Number two, survival was better in HeartMate 3 patients compared to UNOS patients when comparing from waitlist time and thereby eliminating immortal time bias. And number three, HeartMate 3 LVAD patients had a lower proportion of renal dysfunction requiring dialysis and hospitalizations due to infection at 1 year post-transplant, but had a higher stroke rate. And ultimately, he concluded that a strategy of LVAD first in young patients may offer net prolongation of life. So what exactly is net prolongation of life? Well, this refers to the strategy of implanting an LVAD in younger patients with the goal of extending their overall survival by delaying a heart transplant, either temporarily or long-term. And this idea or phenomenon is something that the structural heart teams have thought about for years when managing younger patients with aortic valve disease. And the advanced heart failure community is now thinking about the overall lifespan of a heart failure patient in a similar way. The strategy of net prolongation of life really requires the physician to employ a more expansive view of the management of a heart failure patient. It requires us to think about not only what is best for the patient today, but also best across their entire lifespan. So if we think about an advanced heart failure patient that's, let's say, 45 years old, and we transplant that patient now, by the time that patient is in their mid-50s, it is likely that he or she will need a new graft. And we know that redo transplant make up the overwhelming minority of overall transplants, and they're associated with significantly worse survival. Most patients, in fact, will not have the opportunity for retransplant. This is the unfortunate reality that we live in. Thus, a patient may die in their mid-50s, and we'd likely call it a success. The patient was identified, got transplanted, and lived the duration of the graft. But we'd like to actually re-challenge the idea of success here. Because if we think about that same patient, that 45-year-old patient, and we implant that patient with an LVAD first, he or she now has an estimated 10 plus years of life with a HeartMate 3 LVAD, and still has the opportunity for transplant down the line, which would likely confer another decade or more of life. This patient now has the opportunity to live into their mid-60s. In addition, the LVAD first strategy also facilitates the potential for cardiac recovery, which is an added benefit. So one of the ways I often think about how to frame this discussion about LVAD and transplant patients with advanced heart failure patients is based on their age. And so we'll now walk through some of the data that can be used to frame these conversations. So we just saw 2-year survival in the 90% range in LVAD patients less than 50 years old. And here on this slide, we see 5-year survival in the 73% range in the same cohort. That's that light blue line at the top. This survival certainly rivals that of heart transplant. And so my patients and I have these conversations. We actually talk about the risks and benefits of LVAD first and transplant down the line versus transplant now. Of course, size, gender, sensitization, and clinical parameters such as LV dysfunction inform these discussions, and they also play a role in expected wait times and likelihood of doing well with an LVAD. We also talk about the potential for recovery, particularly for those young patients that are early in the disease course and have not been on GDMT for any extended period of time. In fact, anecdotally speaking, these younger patients often find this idea of recovery quite fascinating, as it provides hope when often they feel hopeless. Now, this is admittedly a busy slide, but I want to point out a few things here. On the top left, we see that survival curve from the prior slide, demonstrating that 73% survival at 5 years for patients less than 50 years old. But moving towards the center of the slide, towards the top, what we see is something really remarkable. The survival in this young cohort is the same regardless of sex, race, psychosocial risk, social support, or ethnicity. Meaning these traditional risk factors that we've historically used to quote unquote disqualify patients for LVAD really should be challenged and potentially even debunked in younger patients. In fact, when we evaluate a young patient in my program, we will almost always find a way to get this patient implanted in order to preserve life. And I do use the term almost always in a calculated manner because I do believe there are some young patients that are not appropriate to implant, but they represent the exception rather than the rule. And finally, I'll add that the totality of evidence supports centers continuously evaluating their selection process to consider expanding VAD eligibility to those populations previously considered too high risk. This slide displays pre-transplant mortality rates among adults waitlisted for heart transplant by age. That's the graph on the right here. And mortality rates are computed as a number of deaths per 100 patient years of wait list time in a given year. As you can imagine, the older the patient, the higher the likelihood of death while waiting for transplant, with patients 65 plus in yellow incurring the highest wait list mortality. And what complements this data nicely is that patients in their 60s that get an LVAD have a 2-year survival that's in the 75% range, which is actually similar to transplant. So when I'm talking to a patient in their 60s about transplant versus LVAD, I make sure they know this information so that they can make an informed decision about choice of therapy, if in fact both therapies are potentially an option. Because as the slide suggests, choosing heart transplant over durable LVAD may in fact be a mortal decision. And then once we get to patients in their 70s, most of these patients will not be transplant candidates due to advanced age and comorbidities. But these patients should know that they stand to benefit a tremendous amount in terms of quality of life and functional capacity, as displayed in the graph here. In addition, these older patients experience significantly lower rates of late complications, and they may actually have the most to gain with LVAD implantation. Now, these older patients have perioperative risk, of course. I don't think it's appropriate to ignore or trivialize the risk of an open heart surgery in someone in their late 70s. But once these patients get through the operation and rehab appropriately, many do remarkably well. So when we have an elderly patient with appropriate goals of care and appropriate support system, we routinely offer LVAD in this setting. We have these discussions, and we actually facilitate and encourage the patient and the family to come to our support group pre-VAD to help enhance their perspective. And now we'll transition back to Dr. Avsal to talk about patient identification and evaluation.
Thanks again. That was an excellent summary of the data for HeartMate 3. So let's kind of shift gears and talk about how we identify these patients in our community. I think it's important for us to start keep a very low threshold to recognize symptoms of advanced heart failure. It's very important for us to identify those patients and then start an evaluation for them as quickly as possible. And I think there's a bunch of different strategies, different programs have utilized for it. For us at our center, and I think Dr. Howard does the same as his, is that we try to co-manage the patients with their primary referring doctors. That could be an internal medicine doctor, but oftentimes it's a cardiologist. And typically what we want them to feel comfortable is that sending the patient to us for a second opinion. If they have a patient with heart failure, they should be able to feel comfortable, say, hey, look, this patient has an EF of 25%. Can you take a look at it, see how we can make this patient's quality of life better? And oftentimes it might be just that we need to make some medication adjustments. We may want to consider other therapy options, and their heart function gets better. We may come up with ideas in terms of revascularization or diagnose some other infiltrative diseases and things along those lines. But then oftentimes we also find those patients that are essentially in that kind of walking wounded state that we always talk about, where they have adjusted and adapted to that lifestyle of not doing much. And so they come and talk to their primary cardiologist or their internal medicine doctor, and they say, I feel fine. And you may want to consider doing some functional testing for them. So it's very important to keep a very low threshold to identify those patients that are refractory to our guideline-directed medical therapy. Secondly, I think it's important to kind of use this rule of 3 to consider patients for timely evaluation. So these are now the patients that are coming to your hospital and getting admitted again and again. So especially if they're getting 2 heart failure hospitalizations in a year, that really should really keep our spidey senses up at that point. Think about, hey, look, this patient may need advanced therapy evaluation within a period of the next month, and we need to consider and come up with a more definitive plan within the next couple of months. It's oftentimes very prudent for you to have a list of these patients that are considered essentially like high risk for heart failure readmissions, possible advanced therapy candidates, and keep track of these patients, make sure we are coming up with, again, a more definitive plan for them. And this is your time to get to know the patient, work on their psychosocial issues, figure out home situation, figure out social support situation, maybe get them to quit smoking or get them to quit using polysubstance use. And that gets us a rapport built up and ultimately get them to a point where if they continue to remain refractory for their heart failure, that we can get them to advanced therapies and not have those contraindications to deal with. Other things to think about in terms of patients that need timely evaluation is escalating diuretic. These are your patients where you get a phone call about them once a week or every other week. Hey, the 2BID of Bumix is not working anymore. And we go up to 3. And next thing you know, a couple months later, they're on 4BID of Bumix and taking a metolazone once a week. That should be a very telling sign that, hey, look, whatever we're doing in terms of meds is not working for them. And the last part of it is the progressive intolerance of guideline-directed medical therapy. So you will notice that even though you're escalating diuretics, you're having to cut down on their entresto and sometimes take them off of entresto and switch them to losartan. And now they're on 12.5 of metoprolol succinate. And those are findings that, again, will tell us, hey, look, we are at a point where we have exhausted our non-invasive guideline-directed medical therapy and not have the quality of life benefit and the mortality benefit that we would want to see. And that's what I mean by doing a low threshold for for having a identification process for advanced therapy candidates. And again, why is this all important? It's because even at a heart failure center, at a VAD center, at a transplant center, we always miss opportunities for patients to be considered for all treatment options. And it happens even more often at community centers where they may not have a heart failure cardiologist or somebody who is championing for heart failure. And that's why it's important to have an early referral pathway set up where patients are not necessarily getting hospitalized, but they have all the pathology that seems consistent for somebody who will need advanced therapies over not necessarily the next year, but maybe in the next 3 to 5 years. And getting them plugged into a heart failure center where they can be longitudinally followed with their primary cardiologist is very helpful to, again, build that rapport, build that relationship, and change the things that could be a contraindication to not be a contraindication going forward. Again, the golden window for referral is for those class 3 heart failure patients that are not able to go up on their guideline-directed medical therapy, that are having more than one hospitalization, that are having more issues from their ICD, they're getting more non-sustained VT. Typically, those are the patients you really want to get them into your clinic and start the evaluation process at that point. The referral too late is the patients that we see in the hospital. And oftentimes we see this almost on a daily basis where they come into our hospital, the LFTs are up, their creatinine is 3. Now we're having to put temporary support devices in them. And now we're really trying to dig ourselves out of a hole to get them to be a candidate. And as Dr. Howard showed, even though the data is great for getting patients from TMCS to LVAD, it's not as good as getting a patient that is an appropriate referral and coming in for an elective LVAD coming from the clinic. So early referral and early evaluation and early implant for in terms of advanced therapies is very important. What we also notice is that 70% of patients in NYHA class 3B eventually progress into class, well, they essentially die before even progressing into class 4. So again, 3B patients really need to be evaluated very closely to make sure that they are not going to need advanced therapies. For our program, what we have done is we keep really close track of these patients. We do a lot of functional testing. It's very common for us to do a cardiopulmonary exercise test on these patients. We keep track of it. And if we see changes happen, that triggers us to do a right heart catheterization. And we discuss these patients as a group. And actually, one of our nurses is going to be presenting this as at HFSA as well, as to how we are trying to make sure we get early evaluation for these patients and not miss that window of opportunity for our patients. And again, inotropes can help symptoms in the short term, but they're not a life-saving therapy. It's not a great idea to send a patient home on inotrope without a plan for definitive therapy. I often tell my patients that this is, again, a bridge to a decision towards advanced therapies, whether that's transplant, whether that's LVAD, whether that's us doing some sort of a valve procedure or something along those lines. But it is not a therapy, it's a bridge to a therapy. And that's kind of what our guidelines reflect as well, that it's not really helpful in terms of long-term support. And most patients that do end up on inotropic support, the average life expectancy is in the 6 to 9 month time frame. So let's shift gears a little bit and let's talk about these patients that are oftentimes the patients that we see, especially at a non-transplant center. These are your patients that have high BMI. These are the patients that are smokers. They may have had a history of substance use in the past. These are the patients that have advanced age. What if they're 78 years old? What if they're 80 years old? They have had a history of recent or active malignancy. They may have renal cell cancer or a prostate cancer, or they may have a nodule that needs ongoing surveillance and is at high risk of being diagnosed for malignancy. Or they may have you may see patients that don't have access. Maybe they live in a very rural area. Maybe there are patients that don't have much of a big family support system around them, or maybe they have financial constraints. How do we evaluate these patients in terms of advanced therapy candidates? A lot of times, a lot of these issues that come up will preclude them from a transplant candidacy. At our center and our system, we typically will not transplant patients over a BMI of 40. So we think about strategies to ideally either get them to become a transplant candidate, or we can consider them for an LVAD. And that should exactly be the thought process on those patients. It should not be the case that we see a patient that looks like they have relative contraindications that we don't think about advanced therapies on those patients because they have these relative contraindications. Our goal as a team generally should be to figure out exactly how we can make the patient a candidate and how we can get a yes from our committee. So let's talk about that evaluation process at a non-transplant program. Again, as a collaboration is going to be key for a program. So if you're a heart failure center, then a close collaboration with a local DT center, which tend to be more in areas that don't have a big heart failure footprint. And then if you are a DT center, then a close collaboration with the transplant center is very important. It helps us do a couple of things. It helps us to standardize our protocols. It also helps us in the evaluation process. So a close collaboration with the transplant center helps you know exactly what are the do's and don'ts from a transplant perspective. And if you have a patient that needs to get transplanted, you're able to get an evaluation done for them on a quick and expeditious fashion so you don't delay the transplant process for them. Additionally, it will help you know what are patients that are going to be reasonable candidates for LVAD. So as you develop your LVAD program, and you're evaluating these patients from an LVAD perspective, you know exactly what are things that you're looking at from a transplant perspective. And if there is a transplant boarded heart failure cardiologist in the program, then that typically helps a lot in terms of looking at contraindications from a transplant perspective as well. As a non-transplant program, I will say that we generally have a different patient population. What I see at our center is that our patient population tends to be older in age. They typically come more from a community setting, and they tend to have less longitudinal care. Our cardiologists are really good at managing heart failure. So you will notice that these patients are coming from centers where they haven't seen a cardiologist, or they're coming in from a locality that they don't have a cardiologist locally. And you see a lot of these patients tend to have more of surgical procedures done in the past, whether that's a CABG in the past or multi-valve surgeries in the past, and they haven't really necessarily recovered from it. So we tend to see a slightly different demographic at a non-transplant center. Additionally, things that lead to being in a community setting and a rural setting also leads to having more issues from financial support, more issues from a social support. They may not have as many family members to support them. And so those are conversations that you're going to start having when you are talking about these patients in the selection committee. And with all of that comes a higher comorbidity burden as well, which we already discussed. So some of these patients have a lot more nuances that you have to deal with. And again, the goal should be trying to figure out how we can overcome these nuances and get them to become a candidate from advanced therapy perspective. So oftentimes when I see patients at our center, they're not necessarily a candidate for advanced therapies. And the goal, again, should be to overcome those clinical and psychosocial barriers. How do we get a yes for these patients? And patients should not get turned down from advanced therapy standpoint from the get-go. We need to first get more evaluation. If they are dischargeable, then we need to have a process set up where we're seeing them very frequently, along with our social team, along with our psychology team, along with our financial team, to see how we can overcome some of those psychosocial barriers. Unfortunately, the reality in our healthcare system is that a lot of times we're having to not pursue advanced therapies, not just for medical reasons, but more so from psychosocial, financial standpoint. So we need to figure out a way to overcome some of those barriers. And again, when we see patients that are possible candidates for advanced therapies, it's important to discuss advanced therapies in general. That includes LVAD and transplant. And that's the reason why a close collaboration with the transplant program helps, because it actually helps you grow an LVAD program and also identify patients from an LVAD perspective as well. And that also helps us keep us on top in terms of the data that is coming out from a VAD and transplant perspective. At our center, what we typically will do on patient evaluation for advanced therapies, we will do a show and tell. Honestly, that is probably the most helpful part for the patient, to hold the device, to see all the nuances with it. We have a very robust patient ambassador program locally, as well as we collaborate with the Abbott program as well. Honestly, I tell the patients this, that I want them to go talk to the patient ambassador, ask them the good, the bad, and the ugly about everything. And oftentimes patients that have hesitation about going forward with an LVAD, after they meet the patient ambassador, they are much more at calm and much more at peace of going forward with the procedure. Oftentimes, patients that are saying, hey, let me think about this. I'll come back and check in with you in a month or so. Discharge me from the hospital when we're really worried about them crashing. If they discharge from the hospital, they go see the ambassador in the hospital, and then they're willing to go forward with the procedure in the hospital as well. So it really helps them understand the device, understand the benefits of it, understand some of the nuances with it as well, and helps us kind of move forward. Repeat conversations, not just with physicians, but the bedside nurses help a lot as well. So having those bedside nurses that are LVAD champions, that know how to take care of LVAD patients, that are taking care of them on the post side, having them talk about LVAD with the patients as well helps a lot too, because they spend a lot more time with us, with the patient compared to us. And so the patients are able to talk to them, converse with them back and forth, and it makes them much more at ease in terms of going through with the surgery. We have a very strong integrated palliative and psychology team, and I think it's absolutely crucial to have that. Again, they are able to help us get understanding of what patients' goals in life are. What are the things that are important to them, and what are their goals in terms of if there are complications that we run into on the post side, how do they want us to handle those complications, and then also address some of the psychological barriers. So a lot of times patients have been dealing with heart failure for such a long time that they have essentially kind of withdrawn from that will to live, and talking to a psychiatrist, talking to a psychologist really helps us kind of overcome some of that. And we have started a lot of patients on antidepressant therapy and things along those lines on the front end, which really helps us get those patients to become candidates and get it and confirm mortality benefit from it. I can't speak enough good things about our social and comprehensive care management team integration. I think it's absolutely crucial for every program to have that. It's very important for us as a successful heart failure program to be able to figure out how to strategize in terms of getting patients their social support they need. And again, we have to be very open-minded about this. It doesn't have to be regimented and set in stone what a social support structure looks like. It might be different for a 35-year-old who's going to be able to take care of their driveline by themselves. It might be different for somebody who's 80 years old. And we need to be a little bit more nimble about our evaluation process with that. And I think that helps us get patients the help they need. And we'll discuss that a little bit more in the case studies that we're bringing up. And again, I mentioned this already, but don't make clinical decision on candidacy based on first look unless there is an absolute contraindication. If there are a bunch of relative contraindications, let's think about strategies on how we can overcome those. And again, highlighting the mortality benefit, the quality of life benefit for the patients goes a long way in terms of making sure they understand why we're bringing this up to them. And that is what our data has shown. If you look at our 2-year post-LVAD quality of life and satisfaction data, 9 out of 10 patients are satisfied with the outcome of the LVAD surgery, and 87% say that they were likely to say yes again if given that scenario again. So some of the variability in a non-transplant program. Again, we talked about having a smaller infrastructure footprint, but honestly, that you can use it to your advantage. You can use it to your advantage to keep your evaluation process more dynamic. When you have a smaller team, you can keep the process nimble, get them presented fairly quickly. We try to get our evaluation done in a 48-hour period, especially if they're inpatient, to not increase their length of stay. And that way we can talk to our surgical colleagues and get a time for the patient in terms of advanced therapy, LVAD surgery date. And that's very important as a team, based on the amount of infrastructure that you have at your center, decide what is an appropriate evaluation time process. Is it 72 hours? Is it 96 hours? Is it 48 hours? And the inpatient setting, is it 1 week, 2 weeks, 4 weeks, 6 weeks on the outpatient? And the goal should be to try to minimize that as much as possible so that we don't have that scenario play out where you miss the window of opportunity for the patient. And at a non-transplant program, and it applies to transplant programs as well, a lot of times we are really on a bed crunch on a regular basis. So we have to be very judicious about our inpatient days. And so making sure that if we can come up with a scenario where we're able to do some of the evaluation outpatient if the patient is at home, instead of bringing them in for every evaluation, that's ideal, because you're going to be able to keep your overall length of stay a little bit lower. And then I do want to dispel one myth of that a DT center cannot take higher acuity Intermax 1 and 2 patient candidates. And I think that's something that I think most of the successful DT programs will attest to as well, is that a lot of times we build these DTs or durable mechanical circulatory support programs on the backs of having high-risk cohorts and having a very robust cardiogenic shock program. Because like I mentioned earlier, as you develop a bigger footprint in terms of heart failure patients, you're going to develop a bigger footprint in terms of cardiogenic shock patients coming in, higher acuity patients coming in. A lot of those higher acuity patients are not transplant candidates for having too many comorbidity burden or contraindications. And it's okay to take those patients from a LVAD standpoint. And and you do a risk assessment from a programmatic standpoint, but a lot of times if we are able to get that cadence and that volume, you're able to successfully do those high-risk patients because you have the ability to also do lower risk patients as well, and keep your programmatic outcomes looking successful. So with that, I will switch over to some case studies, and Dr. Howard and I will present a case each, and then we'll open it up for questions. So let me present this case that actually from about 2 years ago, and this is not your typical VAD candidate or typical VAD candidate, depending on perspective. So this is a 31-year-old Hispanic male. His past medical history included non-ischemic cardiomyopathy, stage 2 chronic kidney disease, hypertension, hyperlipidemia, non-alcoholic steatohepatitis, or NASH, and morbid obesity with a BMI of 54. And over time, he was seeing us in the clinic over a period of 6 months or so, and we started noticing that he was having more heart failure symptoms, and we were having to cut down on his guideline-directed medical therapy. He also had 2 admissions over the last year. After the second admission, he was sent over to us. Past medical history was significant for lobar pulmonary embolism about 2 years prior to presentation. He had been put on some of the weight loss medications. He had lost 15 pounds, but he was turned down for gastric bypass surgery. And despite losing 15 pounds, his BMI was still 54. Social history did include a history of significant alcohol use in the past, but he had not been drinking over the last year or so. He did have history of active marijuana use. He was telling us that it was mostly because he was having shortness of breath, and he wanted to kind of take care of that from with the use of marijuana, as it helped with his anxiety. He has 2 kids, including a 3-year-old, and was in a new relationship. His ex-wife was involved in a joint custody arrangement, but he had a girlfriend for about 3 months. And when we talked to him, it was like, hey, what are you looking for in life? And he said, I just want to be able to run around in the park with my kid. I used to love doing that, and now I can't do that for the last couple of years. And my 3-year-old I haven't been able to do it with her. And during this whole time period, he was getting worse again in terms of symptom burden. So we admitted him again and started him on milrinone. And this is his echocardiogram on the right side. As you can see, he has an LVAD of 7.6 centimeter. He had moderate to severe mitral regurgitation. He has severe tricuspid valve regurgitation, and his RV was also moderately down. We did a cardiac index. His right heart cath showed a cardiac index of 1.2 and elevated filling pressures, as you can see on the right heart cath on the bottom left side. So this is what we brought up to the committee. You're talking about a patient that had a BMI of greater than 50. Obviously, that increases your surgical risk. He also had a history of active marijuana use. He had moderate RV dysfunction and severe tricuspid valve regurgitation. He also had a history of PE, even though his PVR was reasonable and his PA pressures weren't terribly elevated. And then on top of it, he had limited social support. He was responsible for 2 kids in a joint custody. He had a relationship that was only a few months old, and putting somebody in that caregiver position into that relatively new relationship bore its own risk, and he didn't have any other family support around out of that. And those were the considerations that we had to think about. Clearly not a transplant candidate. So what would these things not make him an LVAD candidate? And that was the discussion that we had at our selection meeting. And this is where our social work team and our palliative care team, our psychology team, everybody worked on this together. And the team felt like, and as Dr. Howard mentioned earlier, it's very important for us for somebody especially young like him, that we wanted to give him a chance at life. And we knew that his life expectancy is minimal if we don't do anything for him. And so we decided to go ahead and move forward with this. we made some contingency plans in terms of management, and I'll go over those as well. So we did a 28 millimeter triad band and did the TBR just because he had pretty wide open tricuspid valve regurgitation and underwent the LVAD implantation. He had optimization beforehand with aggressive diuresis on dual inotropes. We were able to diurese him 86 pounds, but yet he's a big guy. So his BMI was still 40 plus. On the post-op side, we did have RV dysfunction as we expected because his RV was down to begin with. He had to go on dialysis for a brief period of time, but we were able to get him off of dialysis prior to discharge. He had severe refractory atrial fibrillation with RVR, and so we had to undergo an AV nodal ablation during that hospitalization stay as well. After about a 3-week hospital stay, he was able to discharge to rehab, and now he's able to walk around. He's able to run around with his kids. He's walking 10,000 steps. He's losing weight, and he's very happy with his quality of life, and is essentially NYHA Class 1. Things that we did in terms of some of the issues that I had mentioned. Again, from a BMI standpoint, we discussed with CT surgery and mentioned that, hey, we're going to try to optimize him as much as possible prior to surgery, get as much volume off to minimize his risk of RV assist device requirements, and also in terms of a surgical planning, given the high BMI. In terms of active marijuana use, we went through counseling. The psychologist was heavily involved in it as well, and we ended up putting him on anti-anxiety medications that we have now gradually weaned off. And in terms of social support, we had extensive conversations with his girlfriend, but then we also kind of talked to him about becoming independent in terms of his driveline dressing changes and things along those lines at a fairly short period of duration. So we're okay with some of our patients doing their own driveline dressing changes if that's what is needed to get them quality of life back. And it just depends upon making sure that they're properly trained for it. And we were able to kind of work on some of the financial aspects with them and help them figure out how to fundraise and things along those lines. So with that, I will hand it over to Dr. Howard.
Thank you. Great case, Dr. Afzal. I think that's a very typical example of finding a way to be aggressive, appropriate, even bold and courageous with a younger patient with multiple potential barriers to LVAD, but successfully navigated. Great job. So case 2 will be, LVAD, it's an option for a younger patient. We talked about that idea of net prolongation of life. In this case, we'll typify that. So we have a 44-year-old male, blood type O, with obesity, not quite as obese as the last patient, but 5'10", 260 pounds with a BMI of 37. A longstanding non-ischemic cardiomyopathy due to a desmoplakin mutation diagnosed in 2006 while in the military, underwent a single-chamber ICD in 2008. So this is a very longstanding cardiomyopathy. Other past medical includes a history of hypothyroidism related to Graves' disease and a prior cardioembolic CVA with no residual deficit. Echocardiogram from 2023, so fast forward in time to a couple of years ago, EF is in the 20 to 25% range, which it had been for many years, LV diameter approaching 8 centimeters. And so, as we often see as patients progress from stage C to stage D, they undergo this cycle of recurrent admissions. And so he ends up with 4 hospitalizations in the summer of 23, with 2 in August, 1 in early August and the second in late August into September. And so a right heart catheterization during that second hospitalization reveals profoundly decompensated hemodynamics, including a right atrial pressure of 20, a wedge of 36, and a pulmonary artery saturation of 36% in the setting of a hemoglobin of 14, which correlates to a FIC cardiac index of 1.3. So this is at the outside hospital. And at this point, he's diuresed on milrinone. And actually, they recognize this. They recognize the high-risk syndrome of these recurrent admissions and these hemodynamics and the fact that he's requiring milrinone, that I need help acronym. And they actually called us and offered him transfer to my center, or the tertiary referral center, but the patient actually declined, as some of these young patients do. They often think they're invincible till they're actively dying. And so during this hospitalization, milrinone was weaned off prior to discharge home. And he was discharged home a couple of days later. And as expected, he represented a couple of weeks later, now in VT storm, multiple ICD shocks, IV amio and lidocaine were added, and he gets a right heart catheterization with even worse looking hemodynamics with a right atrial pressure of 32, a wedge of 42, and an index of 1.1. A balloon pump was placed, milrinone was initiated, then titrated up, and the antiarrhythmics were continued. And ultimately, he's at this point now in extremis or close to extremis, and he's transferred to a tertiary referral center, my center, for ongoing care. So he arrives late in the day with a reasonable map, now on BiPAP for respiratory distress. He's awake but lethargic, ice cold on exam, has moderate acute kidney injury with minimal urine output over the last several hours, and a creatinine around 2 with a normal baseline, lactate around 4. Hemodynamics are shown, CVP around 30, cardiac index around 1.5 with the balloon pump and an inotrope with significant congestion on exam and chest x-ray, and still having a significant amount of VT despite 2 antiarrhythmics. Here's the chest x-ray shortly after presentation. And here's the parasternal long axis, short axis, and apical 2-chamber view. So at our center, with these situations, with these transfers, we typically have a multidisciplinary discussion with critical care, advanced heart failure cardiology, and surgeons, as well as we're considering VA ECMO, which was considered in this place. And ultimately, we decided to cannulate for VA ECMOs to provide him with full biventricular support with the oxygenator, and also allow us to bronch him safely. So he got peripheral cannulation at the bedside via cardiac surgery. And of course, we're having goals of care discussions with him as much as possible prior to intubation, which is of course difficult when patients are in extremis. Wife is at the bedside, and they wanted to be appropriately aggressive in a 44-year-old. A couple days later, Impella 5.5 was placed as an LV vent. He underwent ongoing diuresis, lean of vasoactives, renal recovery, creatinine trends back to normal, RV becomes decompressed with decongestion, and now we have a much better looking chest x-ray. Here you see the profile of the Impella 5.5 as well. This is Impella 5.5 day number 2. ECMO ultimately gets decannulated. He's extubated the day after that. And so now you have a patient with recovered organs. He's awake, he's talking, he's working with PT, he's euvolemic, and he can participate in decision-making. So we actually had this discussion about LVAD now at our center versus transfer for transplant as a male, blood type O. BMI is now lighter. He's around 35 or so after the diuresis and a week or so, a week and a half in the hospital. We talked about the potentially protracted wait time as a blood type O. He in particular was very concerned with this loss of control, with no guarantee of transplant and potential for clinical deterioration while waiting for transplant, as described via the comparative analysis we discussed earlier. And he actually elected for the LVAD. We underwent HeartMate 3 LVAD implanted on Impella 5.5 day number 9. And he had a very uncomplicated post-op course, as we often see with these young patients. Despite this extreme presentation, he stabilized and had an uncomplicated course. He was discharged home on post-op day 14. And to date, now coming up on 2 years, he's had 0 readmissions. He's been evaluated for transplant. He's actually personally, he's a transplant candidate. He's decided to delay listing due to the excellent quality of life with his LVAD. And he wants to get, 6, 8, or maybe even 10 years out of his LVAD before he gets listed, to overall kind of focusing on this net prolongation of life that we've discussed. And with that, we'll start with one question that I want to pose to Dr. Afzal, and then we'll take some questions from the audience. Dr. Afzal, so I talked about this net prolongation of life strategy. Can you share how your team approaches offering LVADs to younger patients? And do you guys talk about this? What's your stance?
Yeah, absolutely. I mean, I think it's important, and I think it's a conversation that you need to have along with your team, with the patient. I think it's important to give the patient the options of discussion in terms of advanced therapies. Hey, your candidate at this point for advanced therapies, whether that's LVAD or transplant, and give them the data about average survival on transplant, average survival on LVAD, and the thought process behind net prolongation of life. As you get the education part done for the patient, and they get to talk to different people, they talk to an ambassador, they get a lot of insights from talking to your team. Patients are able to make that insightful discussion and an answer in terms of what they want to do. It's a matter of preference for some patients. In our thought process, in our experience, some patients have kind of opted for the net prolongation of life strategy, where they feel like, I want to get an LVAD right now. I might have a chance at recovery. There might be a chance at revascularization and recovery of my ischemic disease, or a myocarditis event that's happening, and I might be able to get it explanted, or I might get a transplant down the road. And then some patients will say, hey, look, I really don't want to consider LVAD. I want to consider transplant on the get-go. And I think that's reasonable too. And I think it's a joint decision-making process for every patient, but it's something that we should bring up on a regular basis to our patients, especially in that younger patient cohort.
Thank you.
I think one of the questions, Dr. Howard, is, can you comment on the length of LVAD therapy prior to heart transplant or heart transplant outcomes?
Yeah, and specifically, I want to reference a recent paper in the Journal of Heart and Lung Transplant that essentially showed that the most favorable outcomes for transplant after LVAD occurred when the duration of LVAD was less than 2 years. And so, we talked about this, and when I first saw that paper, it was, of course, a little bit in the face of what the strategy that we just discussed. But we have to think about what that paper actually entails, and it's all patients, including the older patients that get LVAD first and transplanted. And those patients that are in their 60s and even into their 70s, those patients are not going to do as well with 2 major open heart surgeries. It's just the nature of an older patient with more comorbidities. So we're not talking about this net prolongation of life idea in older patients. We're specifically referring to this younger population that, they will shorten their lifespan most likely if you just talk about transplant now. And some patients, as Dr. Afzal just mentioned, some patients don't want to go towards VAD. They want the transplant, and they want the life that affords them, whatever that is. But there is an option and a viable strategy for these younger patients that could potentially extend their overall lifespan with an LVAD than a transplant, because those patients are going to do better with an LVAD than a transplant as a 65 or 68-year-old if you try to LVAD that patient first. I believe probably once you get to your mid-60s, you're probably going to do best with just one operation, and that operation may be a transplant, it may be a VAD, depending on the patient profile and the goals of care, but probably one operation at that point.
Yeah, I think you sum it up perfectly. I 100% agree with you. I think talking about a different patient profile of younger patients and discussion is specifically tailored towards that in terms of net prolongation of life. And I think that paper doesn't necessarily reflect that patient population. A couple other quick questions were, any thoughts on no caregiver implants on qualifying patients?
You want to take that one, or you want me to?
Sure. I'll take that one. So,
okay.
I think it's nuanced, and especially in a younger patient population. I think Dr. Howard referenced that as well. Is I feel comfortable in having those patients be able to manage their own driveline, able to manage their own medications, and when you're talking to them, you can kind of gauge how their medical literacy level and see if you're able to improve their medical literacy level as well, and able to have them manage their medical issues as well. We have a couple of patients that didn't really have a clear caregiver plan that have done extremely well because they were of younger age. Now, if it's an older patient that may not be able to manage things on their end, and they may have a hard time getting transportation arranged and things like that. Those are the patients that I think it gets really tricky when we kind of say, hey, look, they don't have a caregiver at all, and we're going to kind of move forward with it. But again, this is where it's important to have the social worker team as well as the financial team kind of figure out what options do we have for this patient. Can we keep them, get them the ability to rehab for a longer period of time? Is there an assisted living facility that they can be at for a little bit longer, where they can get a little bit more independent prior to getting home? And we have to use some of those strategies as well in those kind of not ideal caregiving plans.
Yeah, I agree with everything, Dr. Afzal, and I'll just add that, you know, the culture and the kind of gestalt of our program has evolved over the years. And I think generally speaking, we're going to be more liberal with caregiver requirements in a younger patient without a ton of comorbidities. It's highly functional. Those patients many of them can take care of the VADs on their own. You know, I'll give an example of a young single male, no kids, no wife, lives by himself, doesn't have a lot of family around, and like he just takes care of himself. That particular patient, you know, we wouldn't want him to find some 24/7 caregiver that now moves in with him for some undefined period of time to do something that we think he can probably just do on his own. Contrast that to a 75-year-old patient with a prior stroke and a little bit of frailty with very aggressive goals of care. You know, that person, we're going to be a little bit more regimented and you know, kind of stern on the caregiver requirement, because we would expect that person to need a significant amount more support. So we do have a caregiver requirement, generally speaking, but it is fluid based on the context of the patient that we are implanting.
On behalf of Abbott, thank both of you for taking time to join us and share your insights on this presentation. A lot of engagements. We do appreciate that. I also want to thank all of you in our audience for taking time to join us today as well.